So welcome to part 5 of today's lesson on disorders of the hypothalamus and the pituitary gland. So for this part of the lesson, you guys should be able to approach to a patient presenting with a Sellar Mass and demonstrate how to work up a patient with unfunctioning pituitary adenoma. So review from your anatomy that any problem with your pituitary can have impacts on the surrounding structure, no? So because what are the structures that are closely related to your pituitary gland, no? Of course, hypothalamus in this area, your third ventricle, your optic chiasm, that's why patients will have visual changes. Your carotid arteries, your internal carotid artery, the cranial nerves, 3, 4, 5, and 6 cranial nerves, 3, 4, 5, 6 cranial nerves. And so any tumors, and of course, your covering sinus in this area, the fenestrated area over there. So any tumor here, depending on its growth, will have impact on the surrounding structures. So for example, if pituitary gland grows this way, you can have hypogonadism. If the pituitary grows within itself, you can have hypogonadism, hypothyroidism, growth hormone deficiency, and even adrenal deficiency or hypoadrenalism. If your tumor goes upward and affects your hypothalamus, you can have temperature dysregulation, appetite and thirst disorders, even obesity, diabetes induced from failure to secure vasopressin, sleep disorders, even behavioral and autonomic dysfunction. If your tumor impinges on your optic or your optic chiasm specifically, you can have loss of red perception, bitemporal hemianopsia, and other visual field loss. If your tumor goes this way, expands this way, and affects your cavernous sinus, you can have ophthalmologia or cranial ophthalmologia because some of the cranial nerves will control your extraocular muscles and even facial numbness. So these are the cranial nerves in this area. You have 3, 4, 5, and 6. Okay. So 3, 4, 5, and 6. If the tumor is quite big, and I've seen tumors that are very, very, very big, can affect the brain, can affect the frontal lobe. If it affects the frontal lobe, you can have personality disorders and also. So how do we evaluate patients with sellar masses? Usually imaging of choice is an MRI. And in the MRI, you can see whether pituitary has a pituitary microadenoma less than 1 cm, a macroadenoma more than 1 cm. So this is an example of a pituitary macroadenoma. Even without measuring, we know this is macroadenoma because the mass has already gone out of the sella turcica. Okay, and as you can see, there is a waistline in the mass. This is caused by the configuration of your sella turcica. And this is what we call the snowman sign. It looks like a snowman in an MRI. Okay, this one is the presence of a dural tail. The mass is attached to the dura, and this is an example of your meningioma. So what are the ways of evaluating sellar masses? Because of the very close relationship of your pituitary to your optic chiasm, it's very important to have an ophthalmologic evaluation, and we usually do this in the clinic through visual assessment. Remember the maneuver where you do this and you do this, and then objectively you can do perimetry. This is an example of a perimetry result, and you can see patient has bitemporal. So these are your visual field for your right eye and your left eye, and you can see the bitemporal hemianopsia. Early diagnosis reduces the risk of optic atrophy, vision loss, or eye misalignment. If you have optic atrophy, it's very difficult to recover the visual loss already. So what are the other things? So this is very important part that I would like to emphasize, the laboratory investigation. The initial hormonal evaluation in a patient with a pituitary incidentaloma. Incidentaloma means a mass is discovered on imaging that was done for purposes. So for example, a patient on, has a vehicular crash, and during the workup for the vehicular crash, he undergoes a cranial CT scan. And in the cranial CT scan, discovered that the patient actually has a pituitary mass. And that's called a pituitary incidentaloma because it was just incidentally or accidentally discovered on imaging. So what do we do? So of course we have to evaluate for any hormone abnormality. So how we do it? We test all the 5 axes: the prolactin axis, the growth hormone axis, the ACTH, the adrenal axis, the thyroid axis, and of course your gonadal axis. So for the prolactin, you just do a beta fasting prolactin. For the growth hormone axis, we screen with an IGF-1. Just uh, uh, you can do this in just one extraction of blood. For the hypothalamic pituitary adrenal axis, we want to screen for hormone excess because this is a mass. We want to see if the mass is secreting excess ACTH. So how do we screen? We can screen for Cushing syndrome, and the ways of screening for Cushing syndrome, you can do an overnight oral dexamethasone suppression test or a 24-hour urinary free cortisol. Or you can do both. Sometimes, usually we do 2 times of any of the screening tests to screen for Cushing syndrome, for endogenous Cushing syndrome. For your gonadal axis, you test for your FSH, LH. For your thyroid axis, you do your thyroid function test, TSH, and FT4. So F3 not included, okay? Just in screening, you just do your TSH and FT4. FT3 is not included. So those are the workup. So based on this, let's say you have a elevated prolactin, then you suspect that probably this mass could be a prolactinoma. If the IGF-1 is elevated, you might suspect the patient to have a growth hormone producing adenoma. So you can do a confirmatory test with a 75 grams growth hormone suppression test. If the patient has a positive overnight 1 milligram dexamethasone suppression test, then you can do confirmatory test. So we'll go to those confirmatory tests if we go to the specifics. For the thyroid function test, you just need a basal hormonal level. So you can actually conclude already whether the patient has central hypothyroidism or hyperthyroidism or not. So how do we treat patients with sellar masses? So after evaluating whether this patient has hormone excess or not, we then decide whether this patient needs surgery or not. So if it's a proteinoma, of course, we do medical management first. But if it's not, then we can consider doing surgery. And the most common surgery that neurosurgeons do is do a transsphenoidal surgery. No? So what is transsphenoidal surgery? So they insert instruments to your nose, to your sphenoid bone, no, and adjust the pituitary over there, no, so that it will only be minimally invasive. Of course, if the tumor is very big, then the neurosurgeon will have a craniectomy. So what are the indications? The correct hormonal secretion, except again prolactin. If there are mass lesions and impinge on surrounding structures, if it's an expanded pituitary mass, it's very symptomatic, visual field defects, cranial nerve palsies, and occasionally they do it in patients with pituitary apoplexy. So you have to balance between maximal tumor resection and preservation of adherent pituitary function. You don't If it's possible, you don't take out the whole gland, because you only take out the adenoma, because if you take out the whole gland, then the patient will need lifelong multiple hormone replacement therapy from pan-hypopituitarism. Okay? So if the surgery does not work, then that's the time that you do radiation therapy to treat residual tumor. But the onset of action is very slow. And the highest rate of pituitary hormone insufficiency develops 5 to 10 years after. So other cellular masses, so remember cellular masses is not just pituitary. So there are other structures there that can cause a cellular mass. And the next most common will be your craniopharyngiomas. Your craniopharyngiomas is from your hypothalamus. No? These are benign supracellular cystic masses from the rapid, usually in a young population, and this can cause hypopituitarism. Craniopharyngioma is impinging already on your pituitary, and can also cause very common central diabetes insipidus in patients with craniopharyngiomas. It's very big, also have hypothalamic dysfunction. These are the other causes, no, of hypothalamic lesions. Okay. Next, we go to a non-functioning pituitary adenoma. So, for example, during the workup, the mass is just a mass. There's no excess hormone production, no elevated, uh, none of the hormones have any symptoms or signs of hormone excess. So it's just a non-functioning pituitary adenoma, but actually they're gonadotropin producing pituitary adenomas. But the gonadotropin production is not enough to really any clinically significant symptoms. No, they can grow as big as like this one. No, the problem with this non-functioning pituitary adenomas, no, is that they can have compressive effects, no, on the surrounding structure, particularly your optic chiasm. Can cause other mass effect symptoms like headache, no? And usually they are still small, they are just incidentally discovered MRI for other indications. Again, that's your pituitary incidentaloma. Some non-functioning pituitary adenoma can have hyperprolactinemia. Now, this is important, okay? This is important because the hyperprolactinemia comes from the stalk compression effect. So for example, the non-functioning pituitary adenoma is impinging or pressing on the stalk where dopamine cannot reach your anterior pituitary. So if your dopamine cannot reach your pituitary, you will have excessive prolactin secretion. Therefore, you will have your hyperprolactinoma. And often than not, this is the only hormone that is abnormal in functioning pituitary adenoma. So how do we treat if you have determined that it is non-functioning? You do you test for the pituitary reserve hormone. Sometimes if the pituitary adenoma is so big, it can cause hormonal deficiencies. You can have adrenal insufficiency, central hypothyroidism, and so on and so forth. So you check whether it's a micro less than 1 cm or a macro adenoma more than 1 cm. As the risk for visual field loss, if there is none, then you can just observe it. The tumor is very small. But if it's a macroadenoma, we usually have to do surgery. And then after the surgery, we test again the pituitary hormones again to see if there was resulting hormonal deficiencies because of the surgery. All right. So now let's go to a case. So this is a case of a 22-year-old male with a 1-year history of progressive loss of vision. And he would notice that he would frequently bump on the walls. So 2 months prior, he developed worsening of vision with episodes of headaches. He consulted an ophthalmologist. And usually they go first to the ophthalmologist because of vision loss. And they did an MRI, and in the MRI, after doing the MRI, they subsequently referred the patient to endosurgery. In the comprehensive review of system, they only noted loss of muscle mass and energy. Otherwise, since this is a 22-year-old male, the past medical history was just unremarkable. And in the physical examination, especially during the neurologic examination, they noted only temporal visual field cuts on confrontation testing, that, and upper and lower extremity muscle wasting. So during the eye, this is what they saw. So what do you think? Is your differential diagnosis? It's a big mass. What do you notice about the mass? The mass is heterogeneous. There are areas of cystic lucencies, areas of high intensity. So this is a heterogeneous mass with cystic lucencies. What is your differential diagnosis? What diagnostic test will you recommend? So again, we go back, We already have imaging, Of course, you're doing your visual perimetry and of course your hormone testing. So during the hormonal testing, they did a prolactin, they did unfortunately, they only did an 8 m random cortisol, but ideally, they should have done a 1 milligram dexamethasone suppression. They also did the TSH and an FT4, FSH, and LH and testosterone. So we're able to test all the axes. Oh, I forgot. This patient should also have an GF. No? This patient also should have an IGF, but I forgot to put IGF here. These are to complete the 5 axes. So the test revealed slightly elevated lactin, normal cortisol, normal TSH, FT4, slightly low LH, and low testosterone levels. So how will you interpret this? So based on the hormonal testing, you will see that the prolactin level is not really markedly high. So remember during our lesson in prolactin, for you to be, if the level is more than 250, you're almost always sure that this is a micro or macro adenoma. Below 250, between 100 to 250, one of the considerations is a stock effect. No? So if we look at this, based on the imaging, based on the imaging, this is a sellar suprasellar mass, so involving both the sella and the suprasellar area. So this is a suprasellar mass, likely a craniopharyngioma. Because of the appearance of the mass, there are cystic lucencies inside. That's very characteristic of a craniopharyngioma. With secondary hypogonadism, one. Secondary meaning the pituitary is the origin of the hypogonadism. You can suspect adrenal insufficiency because of the low cortisol levels. But of course, this still has to be confirmed by 1 milligram dexamethasone suppression test. An ACTH stimulation test, sorry. And then hyperprolactinemia secondary to the stock effect, stock compression effect. So again, sorry, the adrenal insufficiency is for confirmatory testing with an ACTH stimulation test. Okay. So that's the end of the part 5. So I'll see you in part 6. Bye-bye.